This webinar will cover the difficult topic of imaging the post-treatment neck, with particular attention to structured reporting with NI-RADS, but also the timing of surveillance and how to categorize imaging findings from expected post-treatment changes, to focal radiation changes that may mimic tumor recurrence, to findings suspicious for tumor recurrence. NI-RADS can make these cases simpler to interpret, saving you time, adding confidence and clarity to your read, saving your referring clinician's time and energy in deciphering your level of suspicion, and finally, adding value for your patients. We're going to start with the definition and the goals of NI-RADS, and then move on to who and when and where we should be using this template. And finally, we're going to spend the most time on practical application and imaging examples, along with some frequently asked questions and lessons learned. NI-RADS is a risk stratification system and a template for surveillance imaging after treatment for head and neck cancer, with 4 categories of suspicion that we are going to review. The major goal is to standardize the way that we describe and report findings in order to add value and guide management. Who should we be using this template on? Head and neck cancer patients after definitive treatment, and when brings us to the next slide. This is the ACR NI-RADS surveillance recommendation in the asymptomatic patient. It is important that we define surveillance, which refers to evaluation of an asymptomatic patient after definitive treatment with curative intent. It's not imaging in the middle of therapy, that's monitoring response, and not imaging during palliative treatment, that's often also monitoring response, bigger, smaller, and may have a different timetable. Asymptomatic patients are going to undergo clinical surveillance, primarily for mucosal recurrences or palpable abnormalities, and then imaging surveillance for submucosal recurrences and non-palpable lymph nodes. Imaging surveillance should start approximately 3 months after the completion of treatment, often at the end of radiation therapy, and if that's negative, we move out to 6 months, and then another 6 months, and then we can move out to 12 months. It's important that we can interweave MRI into this algorithm for any tumors in and around the skull base. So sinonasal tumors, parotid tumors, nasopharyngeal carcinomas, anytime we're worried about perineural, intracranial, or intraorbital disease. Here are the ACR NI-RADS categories. Category 0, this is a holding pattern waiting on priors, so I do not give this often. This is when I know the priors are imminently available for review, and then I'll score after reviewing the priors. Category 1, this is no evidence of recurrence. Category 2, low suspicion, and as we'll discuss, we divide these into a 2A if it's superficial, because that's really in the purview of our surgeons to assess, and then 2B if it's deep, because these are the deep, ill-defined abnormalities that we just need more data to decide whether it's no evidence of recurrence or whether it's high suspicion. And usually that more data comes with shorter follow-up or a PET. Category 3, these are high suspicion of recurrence, discrete, new or enlarging, and have intense FDG uptake, and the recommendation is for biopsy. The last category is definitive recurrence. These started as only path proven, but we added ones that have clear clinical and radiographic progression, and a recent study showed 100% positive predictive value in this category. Here's a very early paper on the initial performance of NI-RADS to predict recurrent head and neck cancer, and I think this is a great framework. You can see that we had 618 total sites. We scored NI-RADS 1 in the majority, so 85%, and even out to 2 years, these had a low rate of residual disease, 3.8%. NI-RADS category 2, we only scored this 9% of the time, so we only brought patients back for earlier follow-up in 9%, but that is warranted because you can see they have a higher rate of positive disease. 17% of those were positive. On the flip side, 83% were just post-treatment change, so the majority of these NI-RADS 2s are still just focal post-treatment change, but we want to draw attention to those and have either the surgeons take a look if it's mucosal or bring them back for earlier follow-up if it's deep. So NI-RADS category 3, these are the minority, only 5%, that we recommend biopsy. And you can see these have a much higher rate of positive disease. Here's an example of our template. The findings are succinct, saving time for the radiologist. You're basically looking at the primary site and the neck. And in the impression, you can score the primary, and if there's an abnormality, you'll use the pros to describe the abnormality that led you to that particular score. And you may or may not choose to put the legend with the linked management in the report. I think by even giving the score and your level of suspicion, you're moving the patient care forward. We do include the legend with linked management in our reports. NI-RADS 0 is a new baseline study, a new study to your institution where you don't have the prior imaging, but it is available. So you want to go ahead and assign the score and then create an addendum once that prior imaging becomes available. And this will serve as a safety net to prevent you from making mistakes and overcalling abnormalities without the prior. And that's what happened in this case of a base of tongue squamous cell carcinoma that presented to our hospital nearly a year after chemoradiation therapy with this level 2 lymph node that had too much enhancement. So this can't be a NI-RADS 1, but you don't want to jump up to a NI-RADS 3 and recommend biopsy without the priors. So the surgeons, if there are priors available, you're going to ask them, you're going to give it a 3. And then you're going to get those priors. And here now you see the 3-month post-treatment baseline. The node is completely stable and there was no FDG uptake at that time. So that makes us much more confident that this node is a NI-RADS 1. But unfortunately, that's not how this happened. We went ahead and called this a 3 without the priors. We did a biopsy, and when you biopsy a treated radiated node, they can often be really hard for the cytopathologist, and they called atypical squamous cells, and this person went to neck dissection, and so we have path proof that this was a negative node. NI-RADS 1 imaging features. This is at the primary site. You may see non-mass-like distortion of soft tissues, especially if it's post-surgical, or low-density mucosal edema, or diffuse linear mucosal enhancement. In the neck, if you do have residual nodal tissue, it's not enhancing, so it's hypo-enhancing, and there's no significant FDG uptake. And you can see this base of tongue primary with level 2 nodes on the 3-month post-treatment baseline, nothing at the primary site or the neck. So this is a 1 and a 1. NI-RADS 1 pearls and pitfalls. The major pitfalls are being familiar with the more complicated post-resection reconstruction appearance. In these patients, there's often false positives on the PET, and this is an example of tongue fasciculations, and this residual oral tongue tissue can look very mass-like. These are important to become familiar with to avoid that pitfall and overcalling that abnormality. NI-RADS 2 imaging features at the primary site. If the mucosal enhancement is focal or there's focal FDG uptake, we give it a 2A. These are likely going to be post-radiation change, but we point it out to our surgeons and oncologists so they can take a look. This helps them with their clinical exam and increases sensitivity as their exam is also difficult in the post-radiated patient. For the deep abnormalities, we give this a 2B if they're ill-defined and only have mild to moderate FDG uptake. It just means we need more data in the form of short follow-up or a PET to make a decision on what to do next. In the neck, if there is residual nodal tissue that may have a little bit more enhancement than you'd like or mild to moderate FDG uptake, we'll give it a NI-RADS 2 so that we can bring it back for short interval follow-up. Or later in the time course of surveillance, if there's an enlarging or new lymph node that develops, but it doesn't have definitive morphologic abnormal features like necrosis or extranodal extension, we'll give that a NI-RADS 2 because it's not high suspicion. Head and neck cancer patients can also have enlarging reactive nodes. And anytime there's a discordance between the PET and the contrast-enhanced CT, we will give it a NI-RADS 2. And this is an example of a base of tongue that was treated with CRT. And you can see on that first post-treatment 3-month scan, the contrast-enhanced CT has a small, non-enhancing, hypodense ulceration. But on the PET, there's intense focal FDG uptake, which may make some of us knee-jerk to call this a NI-RADS 3. But remember, when it's mucosal, we're going to give it a 2A, direct the surgeon's attention there. And this at 3 months, the FDG uptake went away. Here's an example of an N3 node in the neck. This is larger than 6 centimeters. Often on the immediate 3-month post-treatment baseline, you will see some residual enhancement in this tissue and some residual FDG uptake. So this cannot get a NI-RADS 1. This would be a NI-RADS 2 at least, recommending short interval follow-up. So by the time we saw this outside scan, we recommended an immediate new PET CT, which unfortunately showed clear progression and now rises to the category NI-RADS 3, where we are going to recommend biopsy before salvage neck dissection, and this was residual disease. The pearls and pitfalls in NI-RADS 2 category, it often helps to work backwards. Do I want to biopsy this now? Is it a discrete biopsy target? If you're not the one doing biopsies, be in open communication with your interventional radiologist or whoever is doing the biopsy so that you can get feedback on the lesions that you're sending them. If it's ill-defined and there's not a discrete biopsy target, it's often best to wait, get more data, re-image, or get a PET. NI-RADS 3, for the primary site here, you're going to have a discrete nodular mass that has concordant intense FDG uptake if the PET is available. In the neck, the residual nodal tissue here is going to have residual enhancement and intense focal FDG uptake. Or later in the time course, if the newer enlarging lymph node already has definitive abnormal morphologic features like necrosis or irregular borders. Here's a patient that had a huge T4B adenocarcinoma of the palate that underwent a partial maxillectomy. And on the post-op scan, you can see a focal area of intense enhancement on the PET that actually brought our attention to the abnormality on the contrast-enhanced CT. But when you look there, you saw an irregular margin of the bone and soft tissue. So it's meeting our criteria for a NI-RADS 3, even though it is sub-centimeter. So note that size is not part of the NI-RADS 3 classification. And when you look at the clinical notes, there was a close margin and the patient had refused XRT. So using all the information we have, this is very high suspicion. Remember, when you give a NI-RADS 3 that is not mucosal, this is clearly deep to the mucosa, they're going to likely ask you for percutaneous biopsy, so you can go ahead and be looking for different paths to get a tissue diagnosis, and we did prove recurrence in this case. This next patient had a nasal rhabdomyosarcoma, and this necrotic retropharyngeal node developed later in the time course of surveillance and was definitively had abnormal features of necrosis, and we biopsied this to prove recurrence. So can I use NI-RADS for cancers other than squamous cell carcinoma? Yes, I've just shown several examples. If you are just starting to use NI-RADS, you may want to start small with this subgroup of squamous cell carcinomas so that you can gain some experience first, and then broaden your template for other head and neck cancers. Pearls and pitfalls of NI-RADS 3. The biggest one that I've learned is that radiation injury to the soft tissue or bone can be very tumefactive and mimic tumor. And here I'm showing you the immediate post-treatment baseline PET CT after a big T4A tonsillar cancer underwent CRT, and there's an ulceration with enhancement deep to it and focal intense FDG uptake. But because it's mucosal, we really should give this a 2A. This turned out to be post-radiation, and you can see at 6 months that FDG uptake went away. Here's a NI-RADS 4, clearly a fungating mass at the stomal site for recurrence. This is definitive tumor. If you're thinking about using this at your institution, there are a lot of resources on the ACR page. You can see this category descriptor table. but also flowcharts that walk you through an abnormality, for example, at the primary site, deciding is it superficial, is it deep? If it's deep, is it ill-defined, or is it discrete? If it is discrete, what is the FDG uptake? And then helps you decide on a NI-RADS category and next step. So for the last part of this talk, I'm just going to go over cases and lessons learned, and I want to emphasize how committing to a level of suspicion will help you individually get better, even though there may be ones that you're wrong. And I've shown some examples just of those mucosal abnormalities that early on I was calling high suspicion, and learned to downgrade those to a 2A. But ultimately, I think it's the way that we all reach success and adding more value for our patients. So this next patient's a 57-year-old who underwent resection and reconstruction of big T4A. These are the ones that will often have some FDG uptake, but this is intense and it's very focal. And when you look on the CT, I'm not sure how well it projects here, but there is this irregular enhancement. And we gave this a NI-RADS 3. We were really worried about this, but when we biopsied it, we only got atypical cells. We didn't get definitive squamous cell carcinoma. So now you have a RAD path disagreement. So what if there's not RAD path correlation? Well, the answer is do not stop, and we've learned the hard way on this. If you can't explain it, or you don't feel comfortable that the imaging findings could be tumor-factive treatment change, you either need a repeat biopsy or a surgical biopsy. So it's important to keep up with these RAD path correlations. Here's an example just again of a tongue base that was radiated, a little bit of enhancement of the glossotonsillar sulcus and FDG uptake on that 3-month scan, gets a 2A. But the patient came back at 4 months of the earlier scan because of that 2A and had increasing enhancement and FDG uptake. Now, this is no longer just mucosal and they take a look. It's increasing over time. And this is one of the special scenarios that I will give a NI-RADS 3 for a mucosal abnormality. This patient also, clinically, they could see it. Clinically, there was pain. There were a lot of other clues. But this leads us to the frequently asked question, what if a mucosal lesion is highly suspicious? Can I give it a 3 rather than a 2A? Yes. But often on the first post-treatment PET-CT, even focal mucosal abnormalities are often radiation related, especially if the FDG abnormality is a lot greater than the enhancement. But there are 2 special scenarios where mucosal lesions can rise to high suspicion. The first, if it's an increasing mucosal abnormality that's after that first post-treatment baseline scan, which I just showed you. And the second is if it's a new abnormality that is also beyond the post-treatment baseline scan. So here is a patient nearly 15 months after treatment for a laryngeal tumor and has an ulcerative mass, has new hoarseness, intense focal uptake along this right true vocal cord. So this is clearly a NI-RADS 3 and was a recurrent tumor. What happens if you image patients too early after treatment? So this patient, after CRT for an oropharyngeal primary, got their CT at only 4 weeks. So yes, these nodes look very irregularly enhancing. If this was at 12 weeks, we would be giving this a NI-RADS 3. Here you can see some residual uptake in these nodes. But generally, if they're not in the right time frame, I will give it a NI-RADS 2 and ask them to bring the patient back in the right time frame. But what happened in this case is also not unusual. The surgeon and the patient were too nervous about these, so they went for a neck dissection instead, and it was a completely negative neck dissection. And I think it's just a good learning case that they can look very irregular still with FDG uptake, but if it's not the right time frame, maybe false positive. So what do you do if the timing is wrong? You really need to wait to avoid false positives. So I'll usually score those in NI-RADS 2. This next patient was treated for nasopharyngeal carcinoma with chemoradiation in 2014. So I'm reading the scan in 2019, and you can see the soft tissue in the carotid space is clearly increasing. So to me, that is high suspicion for recurrence. If you wanted, you could add diffusion, look at the ADC values, probably too small for perfusion, but it's really the change over time and the morphology of this that makes it highly suspicious. So this is one that is a rare NI-RADS 3 that I actually didn't feel comfortable biopsying. Usually when it's deep and I give it a 3, it's something I feel like I can biopsy. But occasionally the surgeons are going to have to do an endoscopic or open biopsy, and that's what they had to do here. We did the PET to add confidence before they went to surgery, but they did find recurrent tumor. Can I use NI-RADS on MRI? And again, yes, we're using a NI-RADS template on MR. We presented that at this past ASHNR and are currently working on a lexicon. This next patient had a maxillary sinus squamous cell carcinoma, had undergone maxillectomy and orbital exoneration at an outside hospital way back in 2016. And I'm being asked to evaluate this MRI in 2019. Where you can see there was abnormal soft tissue effacement of the inferior orbital fissure, tracking back to the foramen rotundum. It also tracked down to pterygopalatine fossa. It would be easy to overcall residual tumor, recurrent tumor, and perineural tumor on this case. And while diffusion and ADC or perfusion can be helpful, really what you want to see is the prior. What matters most is change over time when interpreting a surveillance MRI. So you're going to give this a primary 0 and ask for the priors. And now you can see in 2017 that soft tissue was completely stable. And remember that after surgery at the primary site and after radiation, these areas and soft tissue abnormalities may remain abnormal forever. So important to be aware of overcalling perineural disease progression at a single point in time. This next case is a 60-year-old male that had a right-sided T2 oral tongue and had an ipsilateral neck dissection that was negative. And on the very first post-treatment baseline, we see this heterogeneous left level 2/3 lymph node. The reader here gives it a NI-RADS 2, brings attention to it. I think this was a perfectly reasonable score and good discussion. Even though they thought the lymph node may be heterogeneous, it was still sub-centimeter, and the ipsilateral neck had been negative. So they wanted to get another time point, and they suggested a follow-up at 3 months. So when the patient came back at that earlier follow-up, now we can see which direction this node is moving. It's clearly becoming necrotic and gets a NI-RADS 3. We proved recurrence with biopsy, and this went to salvage neck dissection. So this is an example of how patients can move between different NI-RADS scores. If the abnormality becomes more or less suspicious over time, the score can move from that NI-RADS 2 to a 1 or 3 or vice versa. This recent publication just shows the predictive value of our first post-treatment imaging and the value of NI-RADS. So you can see at the primary site, for every 1 unit increase in the NI-RADS score, there was a 2.6 times likelihood of residual disease. And for the lymph nodes, a 5.2 time increase for every 1 increase in NI-RADS score. Also want to highlight some recent publications by colleagues at UPMC and at Mayo, looking at the negative predictive value of category 2 and then the positive predictive value of categories 3 and 4. So this next patient had been treated for an adenoid cystic of the soft palate in 2011, and she was just undergoing MRI surveillance. And I think this really highlights how we can be correct, we can pick up the abnormality, we can describe it well, but if we don't give a level of suspicion, we don't move the patient's care forward. So on each one of these reports I'm going to show you, we describe the abnormality, we compare it to the prior, we were technically correct, but it wasn't until we called it high suspicion for cancer that they went to the OR to remove this and proved that this was recurrent adenoid cystic. So you can see that we brought attention to this retropharyngeal nodes. We used words like somewhat concerning. We compared it to the priors, but it wasn't until we said, you know what, it's not really changed from the immediate prior, but it's still highly suspicious for recurrent disease. And we talked about even what are the next steps for biopsy. And 1 month after that report, they went to surgery. So To me, I learned the power of committing psychologically for us as radiologists, but also for our surgeons to give them confidence to move the patient care forward. This next patient, I'm including our clinical indications section of our template to show how we give the background. We also include HPV status, surgery date, and chemoradiation. So this information carries forward through each case that we assess. And in this case, the patient had been treated over 2 years for an oropharyngeal primary with CRT, and then develops this right 2B lymph node that's heterogeneously enhancing. It was too round. It had clearly enlarged compared to the prior. And you can see that this was read as a 3, high suspicion. And then we used the pros to describe the abnormality, a right level 2B lymph node. You can see that this reader wasn't as sure to go straight to a biopsy, and so they recommended a PET CT as being able to give us more confidence before the subsequent biopsy, but they still called it a high suspicion. And here you can see its intense FDG uptake, and we biopsy to prove recurrence, asymptomatic recurrence, nearly 2 years beyond treatment. So in summary, NI-RADS adds value in that it simplifies our communication. It makes these reports easily understandable with numerical levels of suspicion. I would argue that it makes them easier to interpret. I think most of our trainees would agree these are ones that they actually, these are ones that they cherry pick off the list as being pretty straightforward to read now. So you can see this is an impression from an outside report, and we often do a great job describing the abnormality, and this was in the left glossotonsillar sulcus. But then our impression is that it could be neoplasm, mucositis, or infection. So, and we give no level of suspicion, which leaves the surgeons wondering, what's my next step? Instead, if you give this a 2A, it's a mucosal abnormality, say it's low suspicion, likely post-radiation, the patient's not as worried. The surgeon can just take a look, and everyone is happy. So it clearly directs management. It's okay to be unsure of the diagnosis, but we need to be sure of the next step and commit to our level of suspicion so that we can learn and we can move patient care forward. I've shown several examples of why RAD path correlation is so important, also some examples of evidence-based practice, and finally, this really opens avenues for direct patient reporting and highlights the radiologist's added value. Thank you. I hope that you all learned a little bit more about the post-treatment neck and how NI-RADS can actually help you in reporting and improve communication with your referring clinicians.